So good morning, everybody. I'm hoping you can hear me okay. I'm Lizzy Chambers, Director of Research and Programmes at Together for Short Lives, and I'd just like to welcome you all to this webinar this morning. We've got about 100 participants so far. We are expecting more, but people I think will join as we get going. So again, welcome everyone, and we're really delighted that so many of you can join us here today. We are going to, as you know, mute all attendees at the event just because it will be too noisy otherwise for the presenters. So do just make sure that you are muted. We will have plenty of time for questions and answers at the end of today's webinar. So do put any questions that you have in the chat section of Zoom, and we'll try and get to as many of those as we can at the end. Before we start, really, I just wanted to sort of give my own personal thanks to Professor Lorna Fraser and her team at the University of York for this really excellent piece of research. And also just to say that we were due to obviously have this as our keynote presentation at our conference up in Manchester. We were also disappointed to have to cancel that event. And we thought we can't really wait, we need to do this launch virtually, so that's why we're here today. But do look out for our rescheduled conference later in the year, and we look forward to welcoming you there too. So the order of today is for me to do these introductions and then hand over to our Chief Executive, Andy Fletcher, and then we'll hear from Professor Lorna Fraser herself, and she'll go through the findings from the research. So I will just now hand over to Andy. Excuse the delay. There we go. Hi, Andy.
Good morning. Good morning, everyone. And as Lizzy said, a huge thank you to you all for participating this morning. We were all really disappointed that we weren't able to be together in Manchester, but it's so fantastic to see so many of you on the Zoom call, and also giving up time when I know things are really pressed and busy. Today, as Lizzy said, is a really important milestone, I think, in our understanding of the population of children and young people with life-limiting and life-threatening conditions. And before Lorna gets into the detail of the report, I just wanted to say a few thank yous. A huge thanks particularly to the True Colours Trust for their generous support for the study, and to the advisory group, who have been a really important source of challenge and support and information for the research. So as well as Lorna herself, to Jo Eccleston-Ford, Professor Sir Alan Craft, Professor Myra Bluebon-Langner, Pia Hardelid, Jo Cohen, Rachel Brack, and our own Lizzy as well for their input. I think today's research is a really important building block, as I said, in our understanding of the population, and probably gives some academic, or certainly gives some academic clout to what many of us have asserted for some time, which is the number of children it feels like is growing in terms of population. But I also think it throws down a really important challenge for us all, is how do we respond to that? How do policymakers at a national level design strategies, plans, services and systems to meet the needs of this group of children and families across the health and social care system? How do commissioners at a national and local level design, commission and crucially fund services in children's hospitals, in hospices and at home? How do services themselves work together in new ways to reach as many children in their communities as need their support? And how do organisations like Together for Short Lives support you as services, as professionals, as commissioners and as families to grow and develop children's palliative care across the UK? So in terms of where we go next, as Lizzy said, we were hoping to launch, as well as Lorna's research, we also wanted to launch a big piece of work called Vision 2030, which was looking at 10 years hence, and how that population of children is likely to change, how the kind of economic and social landscape is likely to change, and come up with some recommendations for government for services and for us as an organisation about how we meet that challenge. Now, obviously, coronavirus has changed the landscape in so many ways, but we still plan to conduct that piece of work as soon as we can, and we'll be in touch with you soon to discuss what that looks like and how you can be involved. So enough from me. I want to hand over to Professor Lorna Fraser, who's conducted this with the team at the Martin House Research Centre at the University of York. Huge thanks for joining us today, Lorna, and setting out the report in a bit more detail. So if the technology works, I will hand over to.
Thank you, Andy. I'm looking to Lizzy to check that everyone can hear me.
Yes.
Excellent, thank you. And thank you everyone for joining us this morning. I'm going to start with an apology, just if we have any dogs or child interrupting, I do apologise, but I, like others here, are juggling. Life seems so easy when schools were open. So let me see if I can share the correct screen. Okay, so I'm absolutely delighted to be able to share the findings from the Make Every Child Count study with yourselves today. I would also share my disappointment I'm not sharing this with you in Manchester, although I'm quite happy to be doing it in my jogging bottoms in front of my computer. I'm presenting this on behalf of the whole team, Deborah Gibson-Smith and Stuart Jarvis, who did most of the analysis, and Paul Norman and Roger Parslow as well. So the aim of this study was to both update the current national prevalence of children with a life-limiting condition within the UK, but also importantly to develop a model to predict future prevalence. For yourselves as service providers, commissioners, practitioners, it's interesting to know what's happened in the past and happening now, but it's also really important to try and have some indication of what might likely to happen in the future to enable you to plan your services as effectively and as efficiently as possible. I think it's really important that we talk about definitions, and this piece of work was based on both the WHO definition of children's palliative care that states it begins when an illness is diagnosed or recognised and continues regardless of whether a child receives treatment directed at the disease, and also the more up-to-date Together for Short Lives definition, which again talks about the active and total approach to care from the point of diagnosis or recognition throughout the child's life. Again, most of you will be very familiar with the Together for Short Lives definitions of life-limiting and life-threatening conditions, so I'm not going to read them out, but it's just important when I'm talking about life-limiting conditions, I am including the life-threatening conditions within that. I just choose to save my voice in your ears by not saying both at the same time. So the data that we have available for this study, many of you will have heard me complain bitterly before about both the cost and the time to access some of the data that are routinely collected within our healthcare service. We had for England, we had approvals for an up-to-date data set up to 2017 for inpatient hospital data and also national registration mortality data. So the up-to-date estimates for England and the future prevalence of life-limiting conditions in England are based on those data. Again, many of you will be familiar with the Children in Scotland Requiring Palliative Care, the CHIS study that I led a few years ago, and which has recently been updated by the ISD in Scotland. So again, we already had relatively up-to-date data for Scotland, and we have modelled our future prevalence on Scotland based on the Scottish data. That is for two reasons. One, the Scottish and English data are showing slightly different trends, but also we understand that the population, particularly the demography of Scotland, is quite different to that of England. For Wales and Northern Ireland, we didn't have access to up-to-date data, so we have our estimates are based on the previous data which we had up till 2009-10, and our future estimates are based on what the Scottish data told us. That was a pragmatic decision because, again, the population, the demography of the population in Wales and Northern Ireland is more similar to Scotland than it is to England. So we included children who had a record of a life-limiting diagnosis in a hospital admission in any year in the 17-year time period of this study, assuming that they were aged 0 to up to and including 19. If they did have a record of a life-limiting condition in one hospital year and had an admission, subsequent admission, we included them irrespective of whether they had a life-limiting code or not. That's the same as the methodology we used for the Scottish data, but it's slightly different to the analysis we did in England previously, where they were only included if they had a life-limiting code for that hospital admission. One of the challenges that we've been challenged by around the ICD-10 is the issue that ICD-10 captures groups of diagnoses rather than one individual diagnosis. But also within individual diagnoses, there is a range of severity and complexity that unfortunately we can't identify from the ICD codes themselves. Therefore, working very closely with our advisory committee for this study, we tried to see whether there was any codes that we shouldn't be including. So we did a sensitivity analysis, excluding some codes. The first one was only including children with a perinatal diagnosis up to the age 1. The rationale behind that was we felt if they had a significant life-limiting or life-threatening condition beyond age 1, they would be recoded as having, for example, a neurological condition, which would be picked up by one of the other codes. We also excluded children with an oncology diagnosis once they'd been in the dataset for 5 years, with the hypothesis that they were probably then disease-free at that point from their underlying cancer diagnoses. And the last one we excluded was children with early stage chronic renal failure. That code actually only appears in ICD-10 from 2010 onwards, so actually makes very, very little difference. So what did we find? So for England first, we received a very large data set of just over 8 million hospital episodes for just over 500,000 individuals. And when we applied our inclusion criteria, removing individuals who were older than the age range we're interested in or who weren't English residents, we ended up with a data set of 4.5 million records for 359,643 children and young people. So if we look at the trends in the absolute numbers and the prevalence over the 17-year time period of the study, you can see that the absolute numbers have risen from just under 33,000 to 86,625 by 2017. This equates to a rise in prevalence of 26.7 per 10,000 in 2001 to 66.4 per 10,000 in 2017. It may be difficult to see from the graph, but the rise is steeper up until 2010 and it is not quite as quick in the latter years. As many of you would expect, the prevalence varies quite markedly by age group, with the under 1 age group having by far the highest prevalence throughout the time period, but also rising quickest. And by 2017, we're looking at a prevalence of 226 per 10,000 in the under 1 age group. The prevalence in the other age groups is also rising. If we look by diagnostic group, and here some children had more than one diagnostic group, so the total doesn't add up, but you can see the purple or violet line at the top that has the highest prevalence overall and is also rising quite steeply as the congenital disorders. The other dashed purple line, which is also rising quite steeply over the time period, is the perinatal disorders. And again, these would fit with the rise in the under 1 age group. The red line is neurological conditions and the yellow line is respiratory. Again, there's a rise across the time period in all of the diagnoses, with much smaller rises, for example, in children with a cancer diagnosis. The difference that we see with a higher prevalence in boys and girls is evident throughout the whole time period of the study, and that would fit with what we know. I know that there is a couple of conditions which are specific to boys, such as Duchenne muscular dystrophy, but we also know that prematurity and some other conditions are more common in boys and girls. For the first time in this study, we were able to separate our ethnic groups more than we have been previously. And I think It is important to understand the ethnic and socioeconomic status of a population if you're trying to design and provide a service that can be flexible enough to meet the needs of the whole population. And what you can see quite striking on this graph is the significantly higher prevalence in children of a Pakistani, other Asian and Black populations. And again, this fits with some other work done, for example, by the Bourne and Bradford cohort study, which has shown that the incidence of many complex conditions in children, particularly ones with a genetic basis, which are related to cousin marriages, are known to be higher in the Pakistani population. So the people are always interested in regional variation, and I've already had 2 questions about the underlying numbers for this graph, and we will make those available as an addendum to the report. There is some differences with the prevalence being highest in the northeast, Yorkshire and Humber in the northwest, and lower in East Midlands and east of England. What's not shown on this graph, and is important, however, is over the time period there's a steady rise in the prevalence of life-limiting conditions across all of the government office regions. Socioeconomic status is important, again, when you're thinking about access to and accessibility of services. Now, this graph shows change over time by deprivation group, and these are population-weighted deprivation groups. So if children with life-limiting conditions were spread evenly across the population, we would expect to see 10% in each group. And you can see that there is by far a higher percentage in the most deprived, at around 13%, and lower in the least deprived. And you might say that actually over the time period, the least deprived was actually decreasing their percentage in that. So I said we tried to restrict and exclude some of the ICD-10 codes to make our coding framework a bit more specific. And you can see over the time period, if you compare the top blue line and the grey line on this graph, it's made a small difference. So the absolute number of children would have dropped from just over 86,000 to 81,702, which equates from a change in prevalence from 66.4 to 63.2 per 10,000. So it makes a difference, but not a huge difference. Okay, so it says, why have we seen this change in prevalence? So a good old epidemiologist's bathtub. So at least I don't need to explain what an epidemiologist is at the moment. Everyone seems to understand it, and also if you look at Twitter, has become one in relation to coronavirus. So the prevalence is a function of incidence, so the number of new diagnoses and the number of children dying, with a small number of children in there who may have recovered from their condition. We are using for this study data that is collected within the healthcare system primarily for financial purposes, and that must not be forgotten when we're interpreting these. So what is quite difficult to differentiate between is an increase in children being recorded with this diagnosis and an increased children actually being diagnosed with these diagnoses. We can also make an assessment of any change in survival. So if we look at the number of children being recorded with a diagnosis, you can see over the time period it's increased from a low of around 15,000 per year to high of around 25,000 per year. So there's definitely some evidence of an increase in recording, which may relate in part to an increase in incidence, but may also relate in part into different coding practices. When we look at that by age group, you can see the lightest area at the bottom of the graph is the under 1 age group, and again there is an increase over the time period in the percentage of the new diagnoses in the under 1 age group. There have been a couple of national initiatives over the last 10 years, such as the Embrace project and interest in perinatal care, that may have changed the way that people are coding these data sets. There is, however, also some evidence of increased survival, and you will have seen that in your own clinical practice. Over the time period, the percentage of children dying in this cohort has decreased over time. We do have to be slightly careful about how we interpret the left-hand side of this graph, because we have what we call left edge effects, where we don't know everything about the children prior to 2001. But when we look at the number of children that died in the 0 to 19-year age group, it's steady around somewhere between 1,500 and 1,800 each year. But there are several hundred who are also dying over once they're reaching the age of 19, so in their early 20s. Again, remember towards the right-hand side of the graph, most of these children are still very young, so we wouldn't have necessarily, none of them will have reached the age 19. It's important when we think of the diagnostic groups and we think, are we including the right children here, to show on this graph here the numbers of children dying by each diagnostic group. So it is the highest number of deaths are in the congenital group, followed by the perinatal and oncology. But there are deaths in all of these, and you know, significant numbers in all of these different diagnostic groups. So I would say there is evidence both of increased recording and of increased survival that are together contributing to this increase in prevalence that we see over time. So if we think forward about modelling future prevalence, I don't know how many of you have been following the various different prediction models for what's going to happen with coronavirus, but what that highlights to me is actually this is not an exact science, this is an estimation, and the variation in some of those models show that how, you know, really how carefully we need to be when we're interpreting these. I was very clear that what we didn't want to do when we modelled our future prevalence was just to take a line and continue it along into 2030, because we know we've already shown that the prevalence of life-limiting conditions varies according to ethnic group and according to age quite markedly. So we wanted to take into account what is likely to happen in our population in terms of changes in ethnic groups and changes in age structure over time. Therefore, we did what we call a population-based approach to modelling what's going to happen going forward that adjusts for the changes in population demographics. Again, because this is not an exact science, we have done 3 different versions of our prevalence model. The first one takes the overall data we've shown you up to 2016-17 and said, okay, the changes in incidence and survival and recording we think are going to continue, and we've modelled that with our future population numbers. The second model uses the same statistical method, but it excludes the 4 sets of codes that I highlighted in our sensitivity analysis. And the last model is our very much most conservative model, and what it states is, okay, we know that our survival has increased up till 2017 and there's some change in recording and incidence, but we're going to assume that that doesn't improve in any way, and therefore how would this population look going forward given the population change. So if we look at absolute numbers for England first, you can see that depending on which model we choose, we're expecting by 2030 somewhere between 96,275 and 121,023 children to be living with a life-limiting condition. That equates to a prevalence of somewhere between 67 per 10,000 and 84 per 10,000. What about the other nations? So as I said, the Children in Scotland, the CHIS2 study has been published, and what's important here is to look at what is called hospital-based prevalence, so the dark blue line, the straight blue line at the bottom. And what you can see here that's very different to what we're seeing in England is this plateauing. Yes, it absolutely is a smaller population in Scotland, but you're still seeing over the last 3 or 4 years very little change in the absolute numbers or prevalence of children with a life-limiting condition. Therefore, it was important, we felt, if we were going to model what's happening in Scotland going forward, we use these data. And when we've done that, looking at absolute numbers, we are, sorry if we go back one second, we had an absolute number of 5,671 in 2016-17, and we're expecting that to rise to somewhere between 6,000 and 6,500 by 2030. That equates to a prevalence of somewhere between 51 and 56 per 10,000. Now, I think it's important to try and understand why things might be different in Scotland and England, and I think there's 2 reasons for me. One, the ethnic population and therefore the fertility rates are quite different between England and Scotland. But also secondly, in terms of coding practices, there's much more homogeneity across the health boards in Scotland than there is across the trusts in England in terms of how data are captured and collected. So if we go on to Wales and Northern Ireland, now it's really important that for Wales and Northern Ireland, we're estimating the start and the end here. And we're dealing with a much smaller population. So we're looking at going from somewhere just over 3,500 in Wales to between 3,700 and just over 4,000 children by 2030. And that equates again to a prevalence of somewhere between 51 and 56 per 10,000. Northern Ireland, we're going from a starting point of approximately 2,500 up till somewhere between 2,600 and just over 2,800 by 2030. Now, there is a degree of uncertainty around all of these estimates, but we have made them in as robust a way as we felt possible with the data available. And again, the prevalence in Northern Ireland would be somewhere between 52 and 56 per 10,000. Okay, so we feel there are some strengths, but also some limitations to what we've been able to do with these data. This is a transparent, repeatable methodology. It has been repeated in several different countries now, including Australia, South Korea, and some of the Middle Eastern countries. Is currently being undertaken in Canada and France and Germany. But we mustn't forget these data were not primarily collected for research purposes. There's financial purposes for these data, therefore there is some change over time about how things are collected. We're identifying based on one record of a life-limiting code. We have looked at that and assessed whether we should be looking for more than one record. When we've done that, we immediately lose a lot of the babies, especially the ones that die very young, so that would be something we wouldn't want to do. But I think for me the most important thing that we must do when we're interpreting these data is address the fact that what we have not been able to assess in any way is the complexity of these children. We don't have good enough and granular enough data within the hospital data to be able to do that. Many of you will be familiar with the fantastic work that Karen Horridge and co have been doing with the community services data set and trying to really get some detail on the needs of the children and the complexity. We didn't have access to that data at a national level and able to be doing that. And also, as I said, and you know, as you will understand with the current coronavirus situation, there are uncertainties associated with these projections, but we have been clear about the assumptions that we have made in order to model these data. So in summary, there are marked increases in the absolute numbers and the prevalence of children with a life-limiting condition in England. And I think it's important to say, however you cut this cake, whatever children you decide to include or exclude, there is a consistent increase across time. And that is in partly some evidence of increased recording, but also some evidence of increased survival. The largest increase in prevalence is seen in the under 1 age group, and that is mirrored in the diagnoses in congenital disorders and perinatal disorders. We mustn't forget about the demography of this population and the need to be flexible in order to meet their needs, with the highest prevalence in the Pakistani, other Asian populations, and also in those living in areas of higher deprivation. And I think we do need to think going forward about some further work that really can grapple with this complexity issue and also the relationship with the needs of the child and the family. I'd really want to thank again the research team, particularly Deborah and Stuart, who did most of the analysis. The True Colours Trust for funding this piece of work. Without that funding, we would not be able to do it. Together for Short Lives have been fantastic throughout this. Lizzy and more laterally Myra and Marcella battling with the technology to try and get this webinar up and running. It wasn't as simple as it looks. But also the advisory board members who gave their time and their thoughts and really challenged us going through this study. And it was really important, and we've ended up with a very good piece of work that hopefully you will find useful as a sector. The report, I think most of you had the link to the report, but is available on both the Together for Short Lives and now available on the university website. I'm happy, we're going to do some questions now. There may be some of them that I don't immediately, I'm getting a bit old, I don't remember every single number for every single region, but I'm happy to take other questions by email afterwards. And I'm going to hand back to Lizzy, I think.
Yes, can you hear me okay? Yeah, good. Yeah, thank you so much, Lorna. That's fabulous to see that, that all run through there. I wanted to just say that I wasn't sure if I made it clear that we are recording this webinar session, so people will be able to see this link to this presentation on our website, along with the full report and a summary document as well, which is great. We've had quite a few questions in, and I've been scribbling some down as we go along. So I'm kind of hoping that you're primed, Lorna, can answer them. Should I just kick off with some we've had in? We've had a couple around whether the stats will be available for individual local authority areas or for regions. And I know we debated this in our advisory group, but did you want to just respond to that one?
Yeah, so the overall numbers per year per government office region will be available. They were in one of the initial versions of the report, but there was a rather large number of tables in there. But we can add that back in, Lizzy, and I'll make sure I get an updated version. In the original report we did back in 2010, we put local authority area data in that. We very purposely didn't do that this time, and that's for two reasons, mainly. The variation due to the relatively small numbers by local authority led to quite a lot of misunderstanding and misinterpretation, and I was keen to try and avoid that. We were talking, the main purpose of this was around national level and regional level figures.
Thanks, Lorna. There was a question about whether there's any work to update the stats for young adults. So we went up to age 19, didn't we, in this study?
Yeah, so my memory's going to, I think we have the data up to age 25. We chose to present, the advisory board advised us to present it up to age 19 because we felt that was comparable with the previous study, but also I think in terms of how services are moving in terms of age ranges. So maybe we have that data available, but we haven't as yet analysed it.
Okay. So we'll watch this space for that one then. There was a question here which I didn't understand, but you might understand with your bigger brain than mine, Lorna. It was about how was SES estimated?
I certainly can answer that, and I certainly don't think that my brain's any bigger than yours, Lizzy. We've just read different books, that's all. So the socioeconomic status was assigned by, it is an area level at lower super output area, so an area that contains around 1,500 individuals, and the index of multiple deprivation was assigned to that. That does have some limitations because you're grouping an average of 1,500 people, but also we do know that it does demonstrate the variation in socioeconomic status that we see, but we didn't have any individual level data available on that.
Thanks, Lorna. That is what SES stands for. That's what I was struggling with. There was a question about why the data only goes up to 2017. Why weren't the last 2 or 3 years included?
That's just availability of data and when the length of time it takes to access data from NHS Digital, really. So if we were applying for data today, it would take us a year to get it, and we would probably have up to last year's data. So it's just a time lag. It shouldn't be like that, but unfortunately it is.
Yes. There was a question or comment really just about how much of this is explained by better recording of ICD-10 codes. Yeah, I don't know if you've got any reflections on that.
I have some reflections. I certainly don't think all of it is.
No.
I think because as I alluded to this issue of this very much interest in the last probably 5 or 10 years of care, of the quality of care around the time of birth and in the perinatal period and the national audits that go on that. People are recording more granular data than they did before. So I think there is some element of it. What is really difficult is to differentiate how much of it is due to change in recording practices and how much is also due to change in incidence. The one thing I didn't mention in the presentation and probably should have is we should also remember that for some children, they are now able to get an ICD-10 code, whereas 10 or 15 years ago, we may not have had the technology, particularly for genetic diagnosis, actually to give the child a diagnosis, and therefore wouldn't have been included. So it's a combination between the two. The only way you can really differentiate between incidence and recording is if you have a national register for specific conditions, and bar cancer, we don't for most of the other conditions.
Thank you. I've had quite a long question here. I'll just read it to you.
Okay.
As the figures show a gentle increase in cancer diagnosis, but clinical experience is the number of children with cancer needing palliative care is falling. By including life-limiting and life-threatening, does that obscure a change in the likelihood that a child has a life-threatening rather than a life-limiting condition needing palliative care?
Okay, so I think the first thing to say is that the population of children with cancer within this data set is less than 20% overall. Okay, so they don't overly influence. I think the proportion of children dying from cancer hasn't changed that much in the last 5 years. Is still about 1 in 5. It doesn't show an increase in, this shows prevalence, it doesn't show incidence figures. There has been a small increase in incidence in cancer diagnoses, but what we have shown here mirrors what we expect from cancer prevalence. This was part of the reason for the exclusion of children with cancer after 5 years, and you could see that that made a small difference in the overall prevalence. So it is making some difference. I wouldn't say it doesn't, but it is not. I don't think that's obscuring our whole trend.
Thank you. There's another question about how do you decide which children with cerebral palsies are included?
So I think when we did the original coding framework, again, it's difficult because we don't have the level of detail that we would like. I'd have to go back to the coding framework, but I think we've only included children with quadriplegic cerebral palsy, but I'd have to check. But again, I completely appreciate that that is quite a heterogeneous group in itself, but we are limited by the specificity of the coding framework within hospital data.
There's a question here about the deprivation, and is there a direct correlation between deprivation and ethnicity? So do we know if it's the deprivation or the ethnicity that's the primary factor?
So I haven't displayed the slides for this set of data, but in our original report we did subdivide by ethnic group and by deprivation, and even within all ethnic groups you were still seeing a gradient with deprivation, so it's not measuring the same thing.
Yeah. And there's a question here, I don't know whether we really answered this in this study, but it's a question about the percentage of children who are supported by their local children's hospice.
We didn't, because at this point in time, the children's hospices do not supply any data nationally to NHS Digital in England. I know that CHAS in Scotland has over the last couple of years started supplying data to their to the ISD, which is the equivalent of NHS Digital in England. So when you all get your request to start submitting data to community services dataset, please do, because then we will really be able to answer that question.
Yeah. There's a question about whether the community research that you mentioned, what is that?
What did I mention? Oh,
I don't know, I can't remember.
So I don't know if Karen was going to join. I don't know if she's here or not.
She is on the call.
Is she on the call? So apologies, Karen, if I've got this completely incorrect. So Karen and her team spent a long time working with the Royal College and NHS Digital to capture some, at the point of care. So when the community paediatricians and other paediatricians are looking after children with very complex needs, what those needs were, as well as what medical technologies they needed, what the family needs were, did they need round-the-clock care, all things which are quite key in terms of the level of healthcare need as well as social care need for these children. And that's supposed to be collected by all NHS trusts in England. We know it's not. In Sunderland, where Karen works, they do a fantastic job, but at present it is not, it's not nationally not being collected to the level that we would like it to be. That's also the data set that NHS England at one point were wanting the children's hospices to submit data to.
There was just a question about whether we thought Together for Short Lives, whether our press release was going to get any traction in the middle of coronavirus.
I think that's difficult, isn't it?
That's a question you can answer, Lorna, but yeah, no, it's a tricky one.
I think
we'll do our best.
Yeah, I think it's really difficult, isn't it? Coronavirus is obviously on everybody's minds at the moment. And, you know, we've discussed in length when was the right time to present these data and launch these data.
Yeah.
And I think we wanted to do it before it became out of date. But we have to accept that if we're not talking about coronavirus, it's not likely to be picked up by the media at this point.
A little bit more time. I'll just carry on. We've got quite a lot of questions here. There's a question about whether you'll be doing submitting a paper like you did last time.
The paper is currently under review with palliative medicine. So if any of you guys are supposed to be reviewing it, can you do it, please?
Thank you. There was just a comment, it's a repeat of the question before really, about whether regional data will be included. I think you said you'll add that into the report, haven't you? So
yeah, but just to be clear, it will just be the absolute number by government office region. If anyone wants anything more than that, then we could have a discussion, but we don't, you know, it wasn't resourced within the study.
Yeah. Another question about cancer diagnosis, whether all cancer diagnoses are included or are ones with very good survival rates excluded?
We included everybody. It's difficult because there are, you know, things like retinoblastoma, etc., have very good survival rates, but also are, you know, less than 40 children a year, so we wouldn't skew your statistics that much.
Interesting question here about what do you think children's palliative care services need to do differently as a result of this data?
What do I think?
Yeah.
Okay. Yeah. No, I think I don't think children's palliative care services should be looking after 86,652 or whatever the number was. But I do think there is still inequity in the children that are cared for by palliative care services, and it always amazes me how much of the relationship between services and other paediatric services are down to individual relationships. So if I was running a service and I would be looking at the children we care for and saying, you know, do we have lots of children with congenital anomalies? Do we have any children with congenital heart disease, for example? Do we need to be speaking to our cardiologists and cardiac surgeons? Or we don't have very many children with cancer, is that because they have a very good service elsewhere, and with the Macmillan nurses, that might be fine. But also thinking about the demography and the accessibility for different population groups, I think we shouldn't underestimate the importance of that.
Scroll down a bit. There's a question here about what do you think the reasons are for the higher prevalence in minority groups?
So I think, as I said in the presentation, particularly in the Pakistani population, we know from work from Bourne and Bradford study and others, the genetic conditions, particularly autosomal recessive ones, which are more common in cousin marriages, account for a large proportion in this difference. And there are also some conditions, particularly some of the hematological conditions, which are more common in some of the ethnic minority groups. We also shouldn't forget that fertility rates in the UK in some of the ethnic minority groups are much higher than they are in the white population, and therefore, you know, perinatal and other things are in time of birth may be more common.
Okay, well, perhaps just do a couple more, because I'm aware that I'm probably wearing you out a bit here, Lorna.
I've not lost my voice yet, but
so there's a question here about is the socio-economic data for families measured at the point of diagnosis for each child or at a single point in time?
So it's measured, For each admission to hospital, we have that information. So what we've done on each year the child appears within the data set, we've assigned it based on the information we have in that year. If we didn't have information on the child in that, no, we had information on every child for each year. So yeah, it's based, so it is allowed to change. And I think one of the things that we really don't understand from these data in terms of the relationship with socioeconomic status is how much of this is down to genuinely children having a higher incidence in areas of higher social deprivation. How much is the effect of having a child with very high healthcare needs on the family's ability to earn, etc. So I think
what comes first, isn't it?
Yes, the chicken and the egg, and it's likely to be a combination of the two, I would suspect.
There's a question here about Scotland. It says the prevalence in hospital has flattened in Scotland, not the total prevalence. Is that because children are kept out of hospital more in Scotland?
I don't know if any of my Scottish colleagues are on the call. I don't think I would like to answer.
No.
I don't have any evidence to answer whether they're cared for more out of Scotland or not. I think the graph that I showed, which had the complete prevalence on it, we don't have access to that data from England, so it's very difficult to compare. But as I said in the presentation, I think the flattening within hospital is what I expect we will get to within England at some point. And I think it is down to the different demography and the different recording practices in Scotland.
Just a couple more. There's a question about whether there's a plan to do more detailed research within specific England areas, like Chas has done.
I'm not quite aware of what Chas has done in individual.
I think maybe it just means the CHISP study.
Oh, in the CHISP study. I mean, we have, I did see Andy's name somewhere from Wales. There is an opportunity within Wales that they have some more fine detailed data that may allow us to look a bit more at complexity. But I don't have any further plans to do anything with the English data at this point.
Okay, thank you. And then just an interesting question about with the introduction of SNOMED codes, will this alter how data can be recorded in future work?
Yeah, so that's Karen Horridge's work and the community services data set is based on SNOMED codes, which are much better in terms of being a bit more specific. So yes, it will, absolutely. You know, if we had, what we really want is information from across the whole of healthcare, because at the moment we don't have primary care. That's the main, you know, that's the main piece of the jigsaw that's missing, as well as palliative care, so hospices and other services. At a fine enough level to really be able to identify the children who are on long-term ventilation, the children who are gastrostomy fed, for example. Many of you will have seen the NCPOD report about long-term ventilation that was launched a couple of months ago. You know, we can't even within our data sets at the moment identify those on long-term ventilation. And we should, because, you know, that is in the data somewhere, it's just not collated in a meaningful way.
Yeah. And actually Karen Horridge has commented that if anybody wants any support on how to report data to the NHS Community Services dataset, to look at the RCPCH website, which has got resources, so that would be good.
There's really helpful videos on there as well to show
yes.
What Karen's work has shown.
Yes. I think that's probably where we'll leave it. There's a few more questions. But I think they're more related to Together for Short Lives and how we'll use the data in our work with NHS England and government. But obviously they're going to be pivotal to our work going forward. We need to sort of look at all of our messaging around children's palliative care and what this really means for the sector. So I think we'll leave the questions there. Thank you so much, Lorna, for your time this morning, coming to talk to us all about the study. As I said, we'll have this recording plus the full report and the summary on our website. And look out for things on social media today. I know our comms team are busy tweeting and putting things out. Wait and see what kind of response we get to that. But do engage with that as well. So just thank you again, and we'll leave it there.
Thank you, Lizzie.